All right, article number 7. We're actually going to switch a little bit. And actually, we're kind of getting to that miscellaneous category, I think, here, because this is an article on older patients in the emergency department. It's actually a lovely review. It's from Annals of Emergency Medicine. It's lovely. It's quite nicely done, I have to say.
And in some ERs, I've worked in places, I've worked in ERs where if you stood outside that ER and threw a rock, it broke a window in a nursing home.
Oh, where there's a place where Billy and I both used to work where on a single shift I didn't see anybody under the age of 80.
Yeah, and
there
you'd
is
see people.
Nothing. Your head explodes at the end of a shift
You'd
like that.
see people who are 97 with new onset diabetes where you could just hear their pancreas saying, if you won't die of something else,
I'll do it for you.
We're
done.
I'm just not making insulin anymore. I'm done with this because at 96 you should have dropped dead by now of something.
All right, let's talk about older patients because we see them, a lot of them. The numbers are
because they
really
often call ambulances or ambulances get called for them, which means they're going to come to us.
There's a lot of things.
Yep.
They're up to 1 in 4 ED visits, unless you happen to shift like mine where they were 100% that day.
Yeah.
They come to EDs more often because for a lot of different reasons, but they come to the EDs more often than younger people. They come the increase in number of visits has gone up by 34% in a 10-year time span. And actually, since 2003, we're now up to 2013. It's gone up since then as well, just to kind of fill you in on that.
Yeah.
They come by ambulance. They're sicker when they get there. We do more tests, keep them around longer, admit them more often, admit them to the ICU more often, and make mistakes more often.
Despite we're doing all the testing.
Despite all those tests.
Yeah.
It's a very tough patient population.
And it's also tough in terms of you're wrestling with their comorbidities a lot. They have more drug-related problems, which are easy to miss.
Oh, it's huge. And
there's all kinds of things. And so you try and get a grip on their old record. They don't know the details. And you know it's an old stir when one of these two things happens. Either the old record arrives in a wheelbarrow, or when you summon the old record, you crash the IT system. Then you know that you have an old stir.
Exactly. So the things that we see, and what this article does is breaks it into big categories of the kinds of things that we see when we have somebody come to the emergency department who's older. So one of them is this big kind of garbage bag of neuropsychiatric disorders. And one of the couple of the statements that come out in this article kind of bug me a little bit, but it says a mental status assessment is recommended in all older patients in the ED. Well, you know the people that are so sharper than your consultants at times, and you don't need to do a full mental status assessment on them. But
it's about physiologic age. Some of them are totally sharp, but with it, they have a broken ankle, and if you started asking them what day is it, they'd be looking at you like, who is this little shit?
What's wrong with you?
Really, what's wrong with you?
Now, a paramental status, though, does occur in about 1 in 4.
I remember recently, there was this lady, she was in the room, and there was a hearing aid on the table. Turns out it was not hers. Oh. So I go in the room, and I do my, hi, low voice. I'm Dr. Mallon, and she looks at me, she goes, and I'm just quoting, Rick doesn't like it when I drop the F-bomb, but I'm just quoting this lady. She looks at me, she goes, who the fuck are you screaming at?
So there you go. So don't assume anything. Don't assume anything. You never know. And one thing we do have to be careful of, though, is that sometimes they're not that sharp, and they may have delirium and dementia or both. And delirium occurs, they say, up to 1 in 10.
And they're not the same thing, and you got to know that they have very different things in terms of how aggressive and how much you need to pursue.
And how to pick them apart, how to figure out which is which. So about half of older people that come to the ED have underlying dementia. That's one level. But then on the other level, there's a 10% that have delirium with that as well. And you've got to figure out which is which. So your first job is to figure out, is there a delirium component to this? Yeah. So that's the first step. And there's a table that came in the paper that's actually quite nice to help you sort of get a feel for.
And here it is.
Is this been there a long time, or is this something new that I need to deal with as an acute delirious state? So onset is acute if it's delirious. Usually they were fine yesterday, and then today at breakfast, grandma was acting differently. She was fine at breakfast. She got really loopy in the afternoon. She seems a little better now. That's delirium. Yeah. It's only been going on a day or two, not months or weeks or years. Or vigilance. They're either super vigilant or they're hard to arouse, or their orientation fluctuates. They know where they are and when they are 1 minute, and then they don't an hour later. That is all. Delirium basically waxes and wanes. It's sudden. It's recent. All the other stuff, when it's longer or you can't pinpoint it, it's chronic. That's dementia. So our first job is to see if anybody falls on sort of the right side of that table. Is there anything that makes you think there's something new that has made them
So just
newly
Tuesday,
delirious?
I was working in our fast track, and the mid-level tried to blow by an 80-year-old who the story was the neighbors who like her say she was out screaming at us this morning. I was like, that's
not
delirium,
normal.
and no, we aren't clearing her to psych. We have some work to do.
Right, and
So
part of
let's
this
start doing
is
it.
the chronically demented person, if they have new waxing and waning somethings.
I couldn't get her out of the fast track, though. I
oh.
still had her.
Oh, sorry about that.
Hey, no,
So that's
we went after-
that's point one. Figure out if there's a delirium. Then you need to figure out, is there some sort of, is there a quicker way to do that? Do I have to go through the chart? There's what they did in this paper, just as a quick sidebar, is they have a couple of, if you like these sorts of things, little quick ways to assess certain aspects of an elderly patient that you can use. One of these, of the several we're going to talk about, is the confusion assessment method.
Yep.
Now, this tested very well as far as whether it works or not. And you have a couple of things that you just have to ask yourself or ask the patient. Is there evidence of an acute change from baseline? While you were talking to them, could they focus? And did their behavior fluctuate during the interview? If those answers are true, you're already halfway there. Then if the patient, while you're talking to them, was disorganized or incoherent, and overall you would rate them as lethargic or hypervigilant, all of those say there is an acute delirious state going on here. So here's a slide with kind of putting it all together, but you have to be basically acute onset, fluctuating course, inattentive, and then disorganized or illogical, and some sort of alteration of consciousness, or some sort of alteration of consciousness. And all of that basically said, and to be honest, this is a nice way of putting it on a table that you can figure this out quite easily.
It might lend
you pay
itself
attention.
to a question because
It
it's
absolutely
important.
could. It is important, very important. So here's your delirium sort of assessment state. If they're not delirious, then you need to figure out if there's some sort of dementia going on. And this is actually helpful for a couple of different reasons. You don't have to do the mini mental status exam. That takes a significant amount of time. But there's this thing called the 6-item screener, which is really quick, really easy. And all you do is give
Three
them
and three.
It's 3 and 3. 3 things to remember. You give this little spiel, and it's worth getting a little spiel down because it needs to be reproducible.
I have to have my spiel, so I tell them the 3 things the same every time, so I can remember.
You can
what the
remember. I
three
do the same thing. I actually cheat. I write them on. I have a little book I carry with me. I write them in my book. I use the same thing. So 3 things. They have to repeat it back to you. And then you ask them what year it is, what month it is, what day of the week it is, and then go back and ask for those 3 things. They get 1 point for everything that's correct. So basically, if they miss 2 or more, something's wrong. Okay, and that is a high suspicion for possible delirium, dementia, and that's somebody you may refer on further for other kind of care. It doesn't mean that you do anything crazy, but it means that you probably need to focus more on that person on a more big picture sort of issue. So here's, again, a summary slide of that 6-item screener. You just pick your 3 things, remember them, find a way to remember
Grass,
them.
paper, shoe.
I love that. I don't know, Nirvana. Make sure it's something that they can remember. Now, that's sort of the delirium dementia, but then separate from that is depression, and it's actually really sad. That a third of older patients have depression. And then we think about it. There's a lot of reasons that older people might get depression.
Isolated, lonely.
Oh, their loved ones are dying. It's
Friends are gone.
And getting older isn't fun. So there's a lot of issues that go with it. So there's a depression screening instrument. Again, another sort of thing you can use, but it's again relatively quick and relatively easy. And it's things that you just ask. Do you feel sad? Do you feel depressed? Do you feel helpless? Do you feel blue? If they answer yes to any one of those, it just makes you worry a little more about depression.
Or
again,
if they burst into tears.
well, there's that too. There's that too. That's kind of, they didn't mention that, but that probably should have a little asterisk at the bottom of this particular slide. So those are the neuropsychiatric issues: delirium, dementia, and depression, the Ds. The falls are extremely common, and we think we do this, we see this all the time. And those of us that teach residents all the time, the 67-year-old who fell. Why did they fall? Was it a mechanical fall or did something else happen? And that's the first question you always ask because it's really important. Did they just trip on the edge of the carpet, or is there some underlying pathology or frailty or something that's making them fall? Now, they have a sort of a algorithm, or not algorithm, a mnemonic here, catastrophe, that they use to help you go through the list. And I'll let you sort of go through these in depth on your own, but these all make sense. Get information from the caregiver about the housing situation and information about the fall or if they've fallen before. Is there any alcohol involved? Anything meds related? The T is treatment. Meds related that may have been an issue in contributing to a fall.
And a couple papers that we've looked at long ago in terms of hip fractures said that something like a quarter of hip fractures follow a recent prescription for something like Haldol, Ativan,
or a
pick
change
the
in
said
blood
hip,
pressure medicines.
change in blood pressure,
Right.
or the new fall one is, because we're giving a lot of old people with kidney stones and prostate problems, Flomax.
Right, so they stand up, go down.
Flomax is the new hip breaker.
They go down. So your CAT of catastrophe, again, is caregiver alcohol treatment. The A is affect, so see if they're depressed. That gives you an idea that there's something going on in the background. S is syncope, any history of syncope, because they may have done it again. T is teetering, and this is, again, these things lists kind of reach a little bit, but are they dizzy? Have they recently been sick? Do they have had trouble seeing? Does it hurt when they move? Because stiffness and joint pain makes them more prone to fall. Can they have trouble? Is it trouble with their hearing? Or does their house need to be elder-proofed? Are the rugs a problem? Are there steps? Is there a handle for them getting in and out of the bathtub? All of those things are part of this list, and it's nice and comprehensive, and it's something you can refer to, so you make sure you hit all the things that may have contributed to a fall. Now, 1 in 5 falls is cardiac in origin in an older person.
Hence the rhythm strip with those P waves marching to their own drummer.
Really, just unless they can tell you every single second of what happened. I walked into the kitchen, I tripped on the dog, I fell, I hit my head on the counter as I was going. That if they can tell me all of it, all's good. If it's an unexplained fall, I must have tripped over the dog. That's different.
And the reason, you have to acknowledge up front that for a significant number of older people who are very proud of their independence and things, they often don't really want to they know that the gig might be up.
Absolutely.
They know that long-term care or some change in their life might be coming. So a lot of times they're pretty good about trying to cover for this.
Dance around it. Yep, absolutely. So you have to be careful. And if you don't get a clear story, 1 in 5, it's going to be something cardiac. So get that EKG, listen for that murmur, really pay close attention. You also will see heart attacks, sepsis.
AS.
Yeah, exactly. We just had 2 of those cases the other day on a shift, 2 in the same shift. Medication toxicities, belly stuff like, rupture, AAAs, et cetera. Elder abuse, please don't forget. All of those can cause falls, all of those.
And my favorite one of the meds is, what meds are you on, even though they're old and pretty healthy? No, nothing. Well, what was the last doctor you saw? Well, I saw my eye doctor for my cat. It's the Timolol.
Timolol. It gets absorbed beautifully as it comes down your punctum and into your nose. Who comes in? If they don't recommend they recollect the circumstances of a fall, there's something else that's potentially going on, and actually a high likelihood of something else going on. So those people come in, recurring falls. I've fallen and I can't get up, or you have them in the hospital bed and they can't even get out of bed. Those people really aren't able to take care of themselves very well at home. So that's a recommended trigger for admission. Now, there's a whole separate issue of utilization and all that other stuff.
They won't pass interqual, but you'll have to figure something out.
We're dealing with interqual. Separate story. Not pretty. Now, if they fall, about 1 in 20 or so will get a fracture. They just do, and a lot of them, not most of them, but a lot of them are hip fractures. So if they're going to break something, half of what they break is a hip. The rest is sort of wrists, et cetera. So half of what they break is a hip. They get vertebral compression fractures as well. And I'll tell you, if an older person ruptures a pelvis, breaks a pelvis, they bleed like crazy and they are in big trouble. So fractures are a really common problem with falls. They also get other stuff. The fall from standing hit my head when I am 80 is very different from fall from standing hit my head when I'm 20.
Especially when they're on aspirin or Plavix.
Right,
or
all these other medicines all the new ones that are out there that are just making our lives totally difficult. So they about 1 in 10, up to 1 in 10 will need to be hospitalized for this. And subdural hematomas are more common in older people. Much more epidurals, not so much. Okay, epidurals don't happen because your dura is plastered inside your skull when you're 80. It's too adherent to pull away. Subdurals are much more common. Those stretch veins,
atrophy, anticoagulant. And you have a nice picture
lots
of a
of
CT
space
here with lots of atrophy, but even with an atrophy, a subdural that big starts to
push
squeeze
things
the
around.
walnut.
Exactly. And the trauma may be trivial. Maybe something as minor as hitting their head on a countertop or a cabinet as they walk by. And they may not even remember trauma in these. So it's a big problem. So there's no real good guideline on this, and you have to kind of use your gestalt. But most of us have a relatively low threshold to image the head of an older person who's had any kind of bonk to the head, especially if there's any behavioral issues going on as well. Now, heart disease happens as you get older. It just does. You coat those pipes with the Big Macs you eat your whole life, and you end up with AMIs happening, a third of them in people over 75, unstable anginas, basically most are people over 65. So, and the thing that's frustrating is that they may not present with what we want. I want them to present with chest pain that would be lovely to the left shoulder, would be great. No. They may just present with shortness of breath, and they die more often.
Weakness.
Or I don't feel well today, especially older women.
And people have said that part of the difference, if you want to talk about gender variation, people have talked about gender differences in the workup of coronary artery disease. Some people say that yes, they acknowledge there's a difference, and there's lots of papers that have looked at that, but some people said it's mostly about age. That the difference is that part of the reason women get less aggressive workups is because as you get older, you're less likely to present with chest pain.
And women get coronary disease older.
So you're more likely to have shortness of breath or generalized weakness or fatigue. And obviously that's a harder place to start at in terms of ruling out an MI.
Right. For us, it makes life difficult. So what the American Heart Association said is the following. Because of the high prevalence of atypical features and associated worse outcomes in the elderly, a high index of suspicion for acute coronary disease is advisable, which is actually, it is. We're kind of stuck in trying to figure out where to start the process, which older people do we really do this, but we do need to know that their presentation is atypical more often than not, and often it's shortness of breath, fatigue, nausea, vomiting, syncope. Those may be their presenting complaints.
Although I just have to say, if I kept a high index of suspicion for all the things I'm told to keep a high index of suspicion for, I'd be the most paranoid person on the earth.
It's an incredibly frustrating phase. Now, the other thing is NSTEMI. NSTEMI in younger people is often that ST drops and pops back up and drops and pops back up. It doesn't really do that in older people, so not as much. So that isn't that helpful. And they have left bundle branch block.
So you don't see dynamic changes, so the cardiologist is not impressed.
No,
and then they often have a left bundle, so that also complicates things. We're going to talk more about that in
more
another
about
paper.
That later. Yeah, so that makes our interpretation difficult. So it's just an issue. A newly fatigued 80-year-old woman with a left bundle branch block that's new. What do I do with that? I don't know what to do with that.
It's got a troponin of 0.2
that
people don't want to pay attention to.
So what do I do with that? Now, all the studies say we're terrible at taking care of older people. We don't give them aspirin. We don't beta block them, which is a whole separate issue now. We don't lyse them as much. The reality is they present atypically. It's hard to make the diagnosis. Age in and of itself may be a role as far as getting these meds. So
and they might not be as good a substrate for aggressive treatment.
Right.
So some of that lesser treatment is appropriate.
Right. This isn't necessarily such a huge criticism that we should take so much to heart. Just be very careful with older people. Too hard. With coronary disease. Sorry about that. Yeah. Terrible. That was bad. Didn't mean that. Now, drugs. Drugs. We do this. The average number of medications on an older person in the ED is 4. 13% are taking 8 or more. That's a full-time job. That is insane. You've seen the people that carry the sort of grocery bag full of all their meds. It's absolutely remarkable. And adverse drug effects, the data says it's about 1 in 10 visits in the ED is due to some sort of.
And I think it might
be higher. I do too, actually. I think that sounds kind of low. And it's based, that data comes from studies by using what's called the Beers criteria. Yep. And what Beers did is listed a whole bunch of medicines that are considered inappropriate for older people, and I have a bit of a bone to chew on those because some of those actually are helpful in older people, but you do need to be careful with some of them. If somebody broke their hip, they need to have an opiate. That's not an inappropriate in that situation. But that being said, there are 3 medication classes that account for about half of all of the adverse events that need in older people related to meds that need to see us. Oral anticoagulants or antiplatelets, they're GI bleeding, they bled into their head, they're bleeding. Antidiabetic agents, they get over-treated with these and they get hypoglycemic. And then meds that have a narrow therapeutic index where they don't have a lot of body mass, they don't have a lot of places to put those meds.
And they have changes in their ability to metabolize them
and
conjugate them.
So they get sick easily with those. So DIG and phenitoin are the 2 that they mention.
I thought that was interesting. Anyway?
I think this is emergency medical care, but I see a lot more people actually that are in with other meds as well.
And it's funny that you did say that because I wrote notes for me, which is when we got to this slide, which is increasingly I see problems with beta blockers, and we mentioned the timolol. Increasingly I see problems with calcium channel blockers. I mentioned the alpha blockers with Flomax. Increasingly, and I'm not sure why people are putting them on amio, but of those who are on amio, the endocrinology societies have now recommended thyroid testing on them every 6 months.
Right. Because
fully a quarter of them will get thyroid problems, and in both directions, hyper and hypo.
And they don't manifest either of those as well as the same way as a young person does.
So I felt the need to sort of say, I think there's others involved here, at least from an emergency medicine perspective.
I agree. Although for any test they do, this is the ones they want to hear about.
Yeah, there you go.
Older people drink. They just drink. The data is.
Why have a sidebar when you can have a wet bar?
Yeah, there you go. See, there you go. Up to 14%, and the data is actually pretty strong out there. We don't ever think about this in older people. We just don't.
I do.
Now they don't do well. We do because of our patient population, but in general, the cute little grandma maybe tipping the schnapps that's in her in her freezer. The drugs that they will use if they're illicit, that's actually not very common, but prescription drugs are a problem. The sleeper meds are particularly a problem. I need something to sleep, which, by the way, today, the FDA, I believe, is going to make people make basically some of the sleeper meds now be halved in their dosing for women. So just in general, there's a whole push. All the Ambien type things today, the FDA came out. They're going to have to reformulate. See, look at what you're getting.
That's why I hang out with Diane. So I can be up to the moment.
Now, we do not think about this in older people. We only pick it up 1 in 5 times when somebody has an alcohol or substance abuse problem in the ED. We don't do it. So things like the CAGE questionnaire might be useful. There's no validated screening tools in this in older people, but you could do the CAGE, which is basically, it's the specific questions related to drinking. Now, belly pain, I tell you, belly pain in an older person.
That's a bad story. That never has a good outcome.
Any pain from basically their sternum to their pubis can be horrendous in an older person. They die more often. They have surgery more often. We make incorrect diagnoses more often. And the places where what finally turns out to be wrong with the patient and what we say have discrepancies most often are gallbladder disease, quote, nonspecific abdominal pain. Ooh, be careful with that in an older person. Just be careful. Cancer and diverticulitis are the places we seem to miss things.
So gallbladder disease, the one that gets, it's protein in them, but the other one that gets missed in the oldsters is the acalculous cholecystitis, which kind of is a disease of the, outside of the HIV positive population, which also gets acalculous cholecystitis. If you take them out of the pool, it's a disease of the 7th or 8th decade.
Right.
So you just, and so you're not considering it. So you're like, well, there were no stones there. I did a bedside stone. It's not gallbladder. Yeah, it is.
Exactly.
And then there's a lot of other things that are in there. And the other one that's the sort of pitfall one is I'm constipated. And so, yeah, they are constipated, but that may not cover why they got a temp 101.
Yeah, they don't usually get temperatures from constipation. Even though I'm a little bit loath to throw everybody through the scanner, first of all, the radiation risk long-term for somebody who's older is virtually zip. So as Billy would say, light them up. And the reason it's probably worth it is there's so much pathology that can happen in the abdomen of an older person that is potentially lethal or at least needs surgery or some sort of intervention, that the fact that we order it up to 60% of the time is fine because we make some diagnosis that's important up to 67% of the time.
Right. So the last bullet of this slide really says modifies your admission decision in more than a quarter and identifies a need for surgery in more than 1 in 10, 1 in 9 really.
Right.
So those are very important changes.
Right. It makes you more accurate. So CT scanning actually has been very helpful in our diagnosing older people with belly pain. It's just been wonderful. Now ultrasounds are helpful. I love them for AAAs. I can take a quick look, and as long as I can see that aorta, I can look for a AAA, which is wonderful. And it's great for right upper quadrant pain. So ultrasounds are ordered less often, but for certain things, they're
But beware
wonderful.
the acalculous cholecystitis.
Yes, exactly. Although the wall should be thick.
The wall will be thick.
So the wall will be thick on that one.
But a lot of people hedge, right? You're supposed to get a millimeter for every decade over 40. So they're like, should I be tolerating 4 millimeters or 5 millimeters in this old person? So you get in trouble with it.
True. Now, infections are really common, and the places they get them are the pee and the lung. They just get them there. UTIs and pneumonia are the 2 biggest places.
And the third category is actually the pee or the lungs, only it just went global.
Yeah, right. So it's sepsis. It's all over the
sepsis,
place.
right.
It's everywhere. The other two things to just throw in there as a side is go look at that gallbladder and check out that skin. And make sure that there's no skin source or that the gallbladder's not a source. If you can't find it, those other places, worry about that.
Yeah,
but
I love when a resident wants to start the FUO workup and the socks are still on.
Yeah, it's like, no, take a look. Take a look. There may
What's
be a
under the
Goomba
socks?
under there.
Yeah,
exactly.
What's under the socks?
Now, they may not be febrile.
One of those holes you can probe the bone.
That's right, probe the bone. Dink, dink. So the presentation's atypical in infections. They may just be a little delirious today, but that's it. So they may not have fever. They may not be tachycardic. So they may have just fallen, and they don't usually fall. So look for the infection as a cause of that. So specific things that just tell you the difference between an older person and a younger person. The cholecystitis, basically the CBC is normal almost half the time. It's painless 5% of the time. They're afebrile half the time. So you got to be careful. And appendicitis is the same deal. Afebrile in half. So they're hard to diagnose. The infections have a higher morbidity and mortality. So basically watch them closely. And if you have SIRS findings in an older person, they're tachycardic and a low-grade fever, run with it. Run with it. Now, one of the other things that happens in older people is they're, quote, social admits. They can't take care of themselves. They're falling now all the time. One of the things that this paper brings out, which I think is really important, is that actually there may be some acute medical something in about half of those cases. It may be as simple as a UTI.
Which is the same when you start doing the dementia workups.
Yep,
About
exactly.
half of them have something.
Yep.
The deliriums, many have something,
Exactly.
more than half.
Well, and some of these things are very easy to fix. So literally, if you are 85 years old and very frail, just getting a UTI, a simple UTI, can take you from functional and okay to not so functional. And it's not a social admit because they can't take care of themselves so much as it's a sicker person that needs to be fixed, and then they may be able to be just fine to go home. So look, don't just somebody's brought in because they can't take care of themselves anymore. Look for a reason for that.
So search for the hidden illness, and then next, this slide is about search for the hidden badness.
The hidden badness. So abuse and neglect. This is unfortunately way more common than is reported, because it happens way more often than ever makes it to the reporting stage. This is basically, by definition, quote, is actions or the omission of actions, both of those are very important, that result in harm or threatened harm to the health or welfare of the elderly. And it includes a big range of things, from battery, so hitting somebody, sexual abuse, which is in there as well, abandonment. You're not allowed to drop grandma off at the ER and go to Vegas. You're not allowed to do that. Okay, you're not allowed to.
It's a common thing at our place.
Ours too.
Yeah.
You're not allowed to exploit them, use their house, use their stuff, psychologically abuse them, and tell them they're a big drain on you. And it's if you just didn't have to take care of them, your life would be wonderful. Neglect. You can't not feed them and clean them, and you can't do that. And what's interesting about elder abuse to me is that it's intentional or unintentional. So these people may be the family may be the most well-intended people in the world, but if grandma comes in with a big decube, they are not able to take its neglect, but only because they don't know how or are not able. So again, the point of this is not that somebody's being evil or terrible. Oh, you also, by the way, can self-neglect. So you are not allowed to not take care of yourself, to the point of physical harm or health or welfare of your own. You're not allowed to do that. So this is meant to protect an older person, even if there's people around them trying to help them. It's meant to protect them.
Now, part of the issue here, if you were to ask me, is that when you see child abuse or suspected child abuse, it's pretty aggressively pursued. Mm-hmm. There's a lot of state-by-state variation on who you report elder neglect to. In some areas, it's the quote-unquote the ombudsman for something or other. Mm-hmm.
That's it's a nursing home.
And I feel like they're much less aggressive at tracking things down. Like when you say, I think this is child abuse, cops show up. That doesn't happen with the elder neglects or abuse.
No, we often just end up admitting them and hopefully pass the message on for someone to pursue this even sort of.
And the social workers will tell you it's a lot harder to get it mobilized.
Absolutely. Who gets abused is completely logical. They're more dependent, they're more socially isolated, and if the caretaker, the abuser person, has psychopathology, particularly drug abuse or psychiatric disease,
and
drug
they're
or alcohol
stressed
abuse,
or economically in
big
trouble.
Big problem. So our job basically is to refer, if we can, to recognize it and refer. It's key, though, to recognize this. Now, sort of the overall sort of picture of this is yes, there's a lot of older people who come to the ER. It is completely not realistic for us to do a head-to-toe geriatric evaluation. That's what geriatricians and that whole subspecialty is for. But we do have tools where we can kind of screen for high-risk stuff. There's an overall tool. It's called the Identification of Seniors at Risk tool that helps get some idea of somebody who may need further.
Is that the fourth tool of this
in-depth.
paper, I think?
It is, actually.
Yeah.
There's several, actually. Yes, exactly. And this basically helps
I actually
you.
prefer a power tool.
Yeah, yes, you do.
Yeah.
This helps predict people who are going to come back, the risk of hospitalization, et cetera. And I'll let you kind of read the tool on your own. But what this is meant to do is help you figure out someone that may need social work to come see them, or a geriatrician specifically to see them, to help with things that may keep them at home longer, out of the hospital. So, and this actually tool, if you read it in depth, it's clearly not meant for the ED. It's actually meant for people in an office to help screen.
The other referral that I think doesn't happen enough is they have an illness. They're suffering in some way from an illness, but they don't want to be in the hospital. So getting them outpatient services with pain and palliative care is another.
Oh, it's huge.
Another.
Well,
biggie.
I think pain and palliative care needs to rename itself, because it has this idea of it's just a help you die thing, and it isn't. It's a help you live thing. But it needs to rename itself. All right. So basically, again, if you think somebody's high risk, get somebody involved. Pain and palliative care, social work, a geriatrician, whatever. Our
we go.
points. The percentage of older people is all over the place in the emergency department. They present atypically for lots of things, and you have lots of tools available to you. And what I did in these slides is I didn't list every single little thing again. The meat of it is in the review that we just went through of this. And I think there will be questions on this for sure on the LLSA. And you may have to flip back into the meat of these slides to get to the specifics. But know that this is, I think, an area that they will definitely go for. And it's a huge part of what we do in our practice. Screening may be helpful, so know that. And basically, our goal is to keep people healthy. And we theoretically have a role in this because we see a lot of these people.
Yep.